My name is Jacqueline Leskovic. I am the network librarian for the National Network of Libraries of Medicine, Greater Midwest Region. And today I'm very proud to be the host for our Pride Month presentation on caring for LGBTQ youth. I'm going to move the slide ahead so that we can see ahead. And today's guest speaker is Dr. Catherine L. Imboric, MD. She is at the University of Iowa Healthcare and has been kind enough to share a photo of herself. So those of you who are in attendance from afar can see Dr. Katie and also learn a little bit more about her. She is the associate professor for the University of Iowa. She's medical director for the University of Iowa Healthcare Offsite Primary Care Clinics. And she's one of the co-directors, and I believe co-founders. I could be incorrect. We'll let Katie correct that for us, but she's the co-director of the University of Iowa Healthcare LGBTQ Clinic. Take it away, Katie.
Great, thank you so much, Jacqueline. I'm going to try to share my slides here. So, Jacqueline, if you could tell me if it's working, that would be great. Give me a second, let's make sure. Okay, tell me if you can see that.
Great.
Okay.
I'm gonna have to switch you over to the other share. So let me take myself down. All right. Do our participants see Dr. Katie's slides? Yep. Okay, we're good to go. Thank you.
Okay, very good. All right. So, like Jacqueline said, my name is Katie Imboric, and I'm from the University of Iowa in Iowa City. I'm in the Department of Family Medicine. I've been here for a long time. I did my medical school here and then my residency and joined faculty. And like Jacqueline had mentioned, I did co-found our LGBTQ clinic along with my co-director, Dr. Nicole Knisley, who is a general internal medicine doctor. I won't talk a lot about our clinic because I have a lot of stuff to cover, but if anyone is interested, we have a really wonderful website that you can find just by Googling UIHC, which is University of Iowa Healthcare LGBTQ Clinic. You can read all about our extensive partners, including primary and specialty care providers and ancillary staff. Just a little disclaimer, nothing financial to report, but I probably, during the course of our discussions, will discuss some pharmaceuticals and medical procedures that are unapproved for use by the FDA, and that would be medications and surgeries used to treat gender dysphoria. So the objectives for this hour that we're going to share together is, at the end, you should be able to explain the difference between sex, gender, and sexual identity. You should be able to use respectful language when talking and referring to LGBTQ persons, summarize health disparities affecting LGBTQ youth, and understand factors that increase resilience in this population. So what we're going to start first with is sort of a foundational, what I like to think of as kind of LGBTQ 101. And I am really privileged that I get to talk to medical students and residents and faculty and all around our hospital system and our great state of Iowa. I get asked to speak often. And many times people sort of want me to jump right in and say, please talk to us about how to prescribe hormones. And I'm always hesitant to do that because I think that you can't get to that step unless you really have this strong foundation first. You can't really talk about providing hormones for a population unless you know that you have established rapport with them and created an environment where they feel safe and secure. And when Dr. Knisley and I were getting ready to open our clinic at the University of Iowa in 2012, we held some small focus group sessions with members of the Iowa City community who identified as LGBTQ, many of those identifying as transgender or gender nonconforming. And one thing that we really learned was just how very, very important language is. And it's something that we often, if we identify as non-transgender or as cisgender, or if some of us may identify not as a sexual minority, that we often take that for granted. That we usually don't think about that language. But I want to really challenge us today just to remember that the words that we use when talking to someone or about them, when documenting in a patient's chart, that those words really do matter. And that we have this privilege, and that we can use our privilege for good or for bad. And that I think that this is one of those cases where we can really empower each other and use our privilege for good. So we're going to start first with sex. And I'm a family doc, so I get to deliver babies, it's one of the favorite things about my job. And sometimes, not very often, but sometimes the parents have not found out what the sex of that baby is on ultrasound prior to the delivery. And so what I get to do is essentially I am the one who assigns a sex at birth. So what I used to really just think of as sex, I now have sort of thought of this more so as sex assigned at birth. And so this is really what we're talking about, biology. So it's based on the appearance of physical anatomy, it's chromosomes, reproductive organs, functions. When I'm in that delivery room and I get to assign that sex at birth, I don't usually take a cheek swab and run a karyotype, or I don't grab an ultrasound machine to look at what sort of internal organs that infant has. I simply hold the baby up, look at their genitals, and assign a sex at birth. And of course, there are cases where an infant may be born with ambiguous genitalia. There may also be times where a young child or an adult doesn't progress through puberty as one would expect, or that in the midst of an infertility workup, it's found that that person may be what we call intersex. So kind of an old term for that would be hermaphrodite, and a newer, more accepted term would be intersex, also sometimes referred to as DSD, or disorders or differences in sex development. So we have kind of three options here: male, female, intersex. Even in those cases of infants born with ambiguous genitalia, by the time that they leave the hospital, they will have been assigned a sex at birth, and that is male or female. So then I want to contrast that with gender. And I think that for many of us, we sort of think that sex and gender are one and the same. If you go to, some sort of an office-based setting and they have some sort of form for you to fill out, if it said sex with a line or gender with a line, we may just think that they're asking the same question. But what I really hope to get across today is that those are two very distinct categories. And so gender can be broken down into a number of different words, and one of those is gender expression. All of us made a decision this morning about how to express our gender. The clothes that we wear, the makeup, the jewelry, if we have a long beard or close-shaven face, whatever that is, the way that our hair is cut, our mannerisms, voice, these are all ways that we express our gender. Gender norms are what society and culture expects of those who are masculine or feminine. So it's really sort of what I usually talk about in a group of healthcare professionals, especially if I'm talking to physicians, is I ask how many of the women in the room have ever been referred to as a nurse. And many hands go up, and I ask the same of the men, and hardly any hands go up. And that is just because of what sort of society and culture sort of puts on us in terms of gender norms. I'm going to decline this. Sorry, Brown, CA. And then gender identity is one's own personal sense as a gendered being. So this is not what society or culture sort of puts upon us, but this is our own personal sense of who we are inside. And these terms over here on the right, for those of us who have taken any organic chemistry classes, it sometimes brings back some triggering images, but essentially these are just kind of trying to get to the root of these words. And instead of saying things like transgender and then saying something like, so I have a trans man or a natural man or a trans woman or a real woman, we can simply just use the opposite of trans. And so trans meaning opposite side. And so same side then is cis. So we have cisgender people, so a cisgender man, a cisgender woman, and those are people whose sex assigned at birth aligns with their gender identity. And then we have transgender, so trans man, trans woman, non-binary. I'm going to talk a little bit more about some words related to trans. So trans with an asterisk is written a lot better than it's spoken. So trans asterisk doesn't really kind of roll off of the tongue. But what this is if you think about kind of I have a lot of librarians on the phone, I would assume. So if you did a PubMed search and you had a base term and you put an asterisk after it, then you're going to get results that's everything that includes that base term. And so that's sort of what they're trying to do with trans here, is make it a very umbrella type term. So this is a term that is used to describe people that have an incongruity between their sex assigned at birth and their gender identity. And these folks do not conform to society norms for sex assigned at birth for their gender identity or their expression, so how they sort of walk through the world, and sometimes even their gender norms. So what society or culture would expect of that person based on their gender.
Katie, we have a question coming in. Does gender fluid fall under non-binary in this context?
We are going to talk about that, definitely. And so this is just a little bit more about what does the asterisk stand for. And again, these are just lots of words, including gender fluid shows up on here. When you think about Facebook, so for those of you that are on Facebook, you have options when you choose your gender. I believe that there's 47 options, and the majority of those are some of these non-binary words. And we will talk a little bit more about non-binary folks, I believe, on that next slide there. And I think an important thing also to think about is it's just that these are labeling terms, and we usually sort of lump these under the trans umbrella, but it's always really important to let people kind of self-label and self-identify. These are just a few of some of the options. So first, I do want to stay binary for just a second here before we get to the non-binary. And so what I want to talk first is about some of the transgender terms. I have transsexual here with a line through it. And the reason for this is because really right now at this day and age in 2019, transgender and transsexual, for the most part, many people feel like they mean the same thing. And it's very, very true a sense. Someone who is transsexual is a transgender person who wishes to transition medically with medication and or surgeries. But I would say that this term has become less and less popular. Many people feel like it's overly pathologizing. Some people feel like it is a misnomer. You're not transitioning your sex, you're really transitioning your gender. So I feel sort of similar about the word homosexual. I identify as lesbian or gay, but the word homosexual to me has a lot of negative connotation with it. When I hear that word, I sort of imagine in my mind someone standing behind a pulpit or someone standing on a stump giving a political speech and using the word homosexual with very negative connotations. I think many people feel that same thing when they hear the word transsexual, and so they prefer to use words like transgender. Now that being said, I cannot give you 100% of what people are going to use to identify themselves. It's always best to ask, and I'll talk a little bit about what some of those ways you could ask those questions as we progress forward. But so when we think about transgender terms and we kind of break those down into what that might be, I think that terms like female to male, male to female, and you might also hear those as FTM or MTF, those are maybe a little bit more commonplace. And I would agree with you that it makes it easy to kind of remember, like which way are we going? Where's someone starting and where are they finishing? However, I would encourage you to try to replace those with words like trans man and trans woman. And the reason for that is because if you use a word like trans man, you are really allowing for the breadth of diversity that is inherent in the community. So not every trans man wants to necessarily start and have a vagina and breasts and then finish and have a penis and a male chest. Some trans men do need that to treat their gender dysphoria. Other trans men may just need to change their name, use the pronouns that most align with their gender, and maybe change their gender expression. Some of them may need that plus hormones. Some of them may need that plus hormones plus a surgical procedure. So it really just allows for more diversity, and that is more true to life. And even though you're not saying female to male, you're saying man, you're saying trans man, so you are using the word that affirms their gender identity. So transition is really this process of moving from one gender to the other. It's important to remember that people may no longer identify as trans after transitioning to their affirmed gender. So it's always interesting to me. We ask questions on our intake form when patients come in to see us, and we give them a lot of options for their gender. So we ask everyone what their sex assigned at birth was. We ask what their gender is, and we'll say man, woman, trans man, trans woman, and then you know, some non-binary options as well. We have a number of patients who just select man or woman. And if that was all that we asked was what is your gender, then we would really never know what that person was transgender. So it's really important when we think about medical research and the lack of it, that in our electronic medical records, we should be asking for sex assigned at birth as well as gender, those two questions. And similarly, we sometimes hear words like pre-op and post-op. And so this typically, when people use this, they are referring to gender confirming surgery, so usually genital or bottom surgery. And again, this just isn't really true. Not everyone wants that procedure. Not everyone can afford that procedure if their insurance doesn't cover it. And so pre-op and post-op just sort of assumes that everyone does want those things, and it's just not true. And now we'll get into the non-binary questions. So we really kind of went through, you know, trans men and trans women, which still end up on binary or sort of two sides, if we thought that there were only two sides. But I would like to challenge that whole concept and instead really think about gender as more of a spectrum. And so non-binary people, this again is an umbrella term which can include some of these words like third gender or gender queer, gender fluid. And these are people who don't necessarily believe that they fit into one of those binary gender options. Maybe they feel like some days they are sort of a little bit more one side or the other, and that would be somebody who might be gender fluid. They may feel like there's maybe this third gender, or that they're agender, or that gender is just a social construct. So there's lots and lots of those Facebook terms. Like I said, many of them, most of them are non-binary, different labels. And I think it's that one of my most favorite questions to ask patients when I ask them something like, is there a specific term or word that you use to describe your gender, that I like them to go ahead and explain what that term means to them, especially for some of these non-binary options. So just like these folks may not believe that there's only two gender options, they may not also ascribe to one of our two sort of binary gender pronouns like she or he. They may use pronouns more like they, them, theirs, z, zers, ears, z, here, hears. These are hard to do. It's hard to say. The good thing is that when you are talking to a person one-on-one, you do not, can I ignore this phone call? Okay. You do not usually use pronouns when talking to them, but when you're talking about them, if there's a third person in the room, or if you're talking about them in a case when they're not there, that's when we typically use pronouns. So practice is always a really good thing. I would say that the most common one is they, them, theirs. So I have just a handful of patients that I think use some of these other ones, and this is not an exhaustive list. But I would say that the most common one, other than just using she or he, would be they, them, theirs. And this is how you would do that. So Emily said that we can pick them up around 7. They're really excited for this movie. I can't wait to talk to them about it afterwards to hear their perspective. Jordan said that we can pick Zia up around 7. Z is really excited for this movie. I can't wait to talk to Zia about it afterwards and hear Zia's perspective. Okay. And now we're going to move into sexuality. So we've talked about sex assigned at birth, gender, and now sexuality. But I don't want you to forget what we just learned about gender, because this really is our sort of point of reference, okay? So sex assigned at birth, or sex, isn't the point of reference. The point of reference is gender. And I'm not going to spend a lot of time on this slide, because I think that most folks might have, or might be a little bit more familiar with some of these terms, although there for sure are some that I'm going to kind of talk about. So homosexual, I put a line there. Through that, like I'd mentioned earlier, I think that some folks feel like that's sort of overly pathologizing. As many of you may or may not know, it was included in the psychiatric manual, the DSM, until 1973. It was listed as a psychiatric illness, and it was removed at that time. And so some that folks may not be as familiar with would be aromantic, sometimes referred to as aro, or asexual, or ace, people might use. So aromantic would just be folks who do not feel like they have any romantic attraction. Asexual would be people who don't feel like they would like to be sexually intimate with people. Demisexual are kind of, demisexual would be those folks who are kind of the anti-one-night standers. So they feel like they need to to really have an emotional relationship and emotional attraction to someone before they can be sexually active with them. Pansexual or pan, I often think of as sort of, you know, a little bit of the 2019 bisexual. These are folks that on Match.com, they wouldn't click any filters. So they would find themselves potentially attracted to people regardless of that person's gender, be it cisgender man, cisgender woman, transgender man, transgender woman, or a non-binary person. Queer in its truest sense could kind of replace all of the LGBTQ letters. So queer is anyone who identifies as a gender or sexual minority. So it is kind of the umbrella of umbrella terms. However, we don't often kind of use that by itself, at least we do not at the University of Iowa. Our clinic is called the LGBTQ clinic. And so we have 2 Qs, queer plus questioning. And the reason is that, as many of you know, that it had been used for quite some time in a quite derogatory sense. And while I think that the younger population has successfully so reclaimed this term and turned it around to be very positive, there are some who really do not identify with that term, and it can be quite triggering for them. And then we have these terms of behavior. And as a medical doctor, these are often things that I think about, sort of what is someone's sexual behavior, because I'd like to know what their risk factors are and how I can talk about screenings and or anticipatory guidance and health promotion. So MSM, men who have sex with men, WSW, women who have sex with women, WSWM, women who have sex with women and men. And for trans people, there's just too many moving parts to only have 3 letters. So you really need to know what type of body parts does your trans patient have, what type of body parts does their partner have, and how do they put those body parts together? So we have defined LGBTQ. Oftentimes I'm throwing in this plus, and so that plus can mean anything else. It's sort of becoming a quite long list. I've only placed a couple of them there. So intersex, two-spirit, ally, asexual, etc. So LGBTQ plus. And there's the color of the rainbow for folks who don't know. This is a really good one for your pride trivia. It's Roy G. Biv, right? Red, orange, yellow, green, blue, indigo, violet. All right, so next we're gonna sort of get into some more nuanced discussion about kind of language and sexual orientation and gender identity. So even though it's LGBTQ, we sort of lump it all into one population. I think it's really important to remember that sexual orientation and gender identity are completely separate. Just because we know what somebody's gender identity is does not mean that we know what their sexual orientation is. So just because we know that someone is a trans woman, it doesn't tell us anything about her sexual orientation, which may be lesbian, or she may identify as straight, or pansexual, or bisexual, or we can think about that whole entire list. So one of these does not predict the other. They are separate. And with sexual identity, I like to think of this really as kind of 3 separate parts. And I'm a family doctor. I'm really big into kind of caring for the whole person, and in fact, caring for that whole person in the midst of their family and their community and all sorts of things. But when I think about kind of that person's sexual identity, I think it's broken into 3 parts that we often just make assumptions about. So for instance, if I know that I have a married man and that he's married to a woman, my assumption is that his attraction is only for women, and that his behavior is only having sex with his wife, and that his orientation would be straight. And that's just not really good assumptions to make. I mean, I could tell you countless stories of when these 3 things don't necessarily match. So I think that it's really important, especially when we talk about LGBTQ youth who may not have made decisions about all of these things, to sometimes really start with their attraction. So who is it that they're attracted to, and who is it that they're sexually active with in terms of their behavior, and then what is their orientation? Sort of how are they self-identifying? Are they using any specific terms or words to describe their sexuality? Really quickly, I wanted to touch on bisexuality and sort of this whole concept of bisexual invisibility and erasure. And this is a real thing. For many people who identify as bisexual, they can often feel invisible, both in the straight community, if their partner happens to be of the same gender, or in the gay or kind of in the LGBT community, if their partner at the time happens to be of the opposite sex. And there's oftentimes, even within the LGBT community, that bi people can be told things like, oh, that's just a phase, or you know, like, this isn't real. Why don't you pick one or pick the other? And I think that we can see this played out when we really look at some of the health disparities, and we see that there are times where folks who identify as bi are disproportionately affected. And I think that it's even because they don't necessarily have that community that they really feel at home with, and that community may change based on who their partners are. So these are some really great slides, and they come from this super cool website that's called it's called Metrosexual, and they came up with things like the genderbread man, if anybody has ever seen that, which is a really great exercise as well to sort of do some self-reflection about your own gender. But so instead of saying things like hermaphrodite, like we talked about, you can use the word intersex. Homosexual, you can use the word gay. Instead of saying born female, male-bodied, natural man, you could just say things like assigned female or male at birth, and never using words like a gay or a transgender, but using it more so as an adjective, so a gay or transgender person. And similar, instead of using things like a normal man or a real woman, just use the word cisgender. So you have transgender people and cisgender people. And we could really try to expand from the binary. So oftentimes you will see things like both genders or opposite sexes, and we can really be inclusive of our non-binary friends if we use words like all genders. Similarly, we do, you know, very binary language, just everyday ladies and gentlemen, mailman, fireman. So we can use words like everyone or male clerk, firefighter. And if we don't know what someone's pronoun is, then we can simply just use the word they. They, I believe, is the Merriam-Webster word of the year, I think, in 2018, or it might have been 17 even. So even though your grammar teacher may be rolling over in her grave to hear you use a plural pronoun to describe a singular person, when you get used to it, it really does sort of just roll right off of your tongue. They're ready for you in room 10. I'm not sure what time they're going to show up today, whatever that might be, but they is a great way to use someone's pronoun or to pronoun them if you don't know what pronoun that they prefer, until you ask them what that is and then use their pronoun that they would like. So here are some tips and tricks for talking to humans. And the reason that I say humans is because we don't know who's gay. So this isn't something that we can necessarily just turn on or turn off. We don't know who's trans. So my recommendation is just to try to incorporate this way of talking in this language into your everyday conversations. So instead of asking people, do you have a boyfriend or a husband, if you're talking to someone who is a girl or a woman, or do you have a girlfriend or a wife, if you're talking to boys or men, you can just ask if you have a partner or a spouse, or simply something open-ended. Are you currently in a relationship? And if they say yes, tell me about it. So avoid assumptions. Recognize that for many of us who are heterosexual and or cisgender, that we really have some heterocentric and ciscentric beliefs and privileges. They are ingrained in us. They are what we see on television. They're what we have grown up with. And we need to sort of pause and think about what it would be like to walk through the world as someone who is not cisgender and not straight. Remember that relationship status may not predict identity, and that orientation may not equal behavior and may not equal attraction. I think that always some of the best things, if you haven't specifically asked someone yet what specific terms or labels that they use to describe themselves or that they prefer that other people use, I think it's helpful just to listen to what that person says and echo it back to them. So even though gay marriage is legal, thankfully so, and we have lots of gay and lesbian people who have gotten married, not all of them refer to their partner as wife or husband. So really try to listen to the language that that person uses and then use that back to them. Similarly with queer, I know that you all are really going to feel empowered after this conversation, and I'm super excited for you to try these things out. But I would say don't run out to your first kind of person that who may identify as LGBTQ+ and say like, so tell me how the queer community is getting ready for Pride. They may or may not identify with that word queer. Again, this one is where I think you can kind of walk on eggshells just a little bit. And so if we're talking with trans people, I do really feel like it's so important to ask about preferred name and preferred gender pronouns. And I don't know where all of you are from or what sort of the current trend in your institution is, but I know that in my email signature, it's something that I've added to the bottom line. So I say that my pronouns are she, her, hers. I think that I've seen it on a lot of business cards. It's becoming more commonplace, especially in our places of higher education. The first day of class, this is something that is just sort of said. And I think that that's really wonderful and great. And if we get to that place where it is as common as saying, hi, I'm Katie, what's your name? Then that would be wonderful. Right now, I think that most of us are at this place where I like to call it sort of the reasonable person. And if you as a reasonable person sort of meet a student and that student's legal name is Michael, and yet the student comes in and has clothing that is feminine and has makeup on and whatever else, and you just think this person's gender expression is kind of non-conforming, that it would be a great time to say, hey, my name's Katie, my pronouns are she, her, and hers. What's your name and what pronouns do you like to use? And that's as simple as it is. So ask about their preferred name, their preferred gender pronouns, honor those when talking to them and about them. And if you make a mistake, which you will, own it. Don't just think, oh gosh, they're probably misgendered and mispronounced 10 times a day, because they probably are. But the number of times that someone actually apologizes to them and says, oh my goodness, I'm so sorry, I'm really trying and I'm gonna do better, is definitely a low percentage. So be that person that does that. All right, now we're gonna transition a little bit now that we've set the foundation and spend the next hopefully 12, 15 minutes here talking about about LGBTQ plus youth. And while I want to really start and kind of throw out some statistics, many of which are sobering, I also just want to kind of say from the beginning that that I feel like LGBTQ research and publications at this point in time have somewhat shifted, and I think appropriately so, because we definitely have the data that we know that the disparities exist. But we are starting to see this shift towards more of a strengths-based model, or a resilience-based or health promotion-based, that we know that these things do happen, and yet we should really start to focus on, but what about those who may be the exceptions to this rule? What is it that is going on in their life that has improved or increased their resilience, that in the face of difficulty, they've still been able to achieve high outcomes? How can we learn what that is and really put that into practice to help support LGBTQ people? So the first thing that I want to start with is really just saying that it is not inherent in an LGBTQ person that they are less healthy or that they are more prone to having high risk behaviors. This is a product of the environment of which they live. And that environment is probably personal, and that environment is systemic and institutional. So they experience stigma at many, many turns of their life. Some of them experience bullying or violence, discrimination, and compile that with rejection, from their family. It would be the most significant, but also from their peers or their social networks. And it's those things that really lead to increased stress. It's those things that also can lead to things like internalized homophobia or transphobia. And then that is what they believe increases the risk behaviors that lead to poor health outcomes and health disparities. So one of those would be talking really about HIV. And so these are, this is some data from the CDC from 2017, and it was new HIV diagnoses. And they sort of define youth as ages 13 to 24. And so you can see that male-to-male sexual contact still includes a very high percent of these new diagnoses, so 93%. And we had just over 7,000 young men of that age range who were diagnosed with HIV last year. And when you break that down by ethnicity, you can see that there's also this really important intersectionality of race and ethnicity as compounded by things like their sexual behavior. So Black and African American, gay and bisexual men make up a disproportionate amount of HIV diagnoses, as do other people of color like Hispanic and Latino people. The other thing I wanted to talk about was just some barriers to care, and this is one reason and one hypothesis why some of the health outcomes are poor for this population. And some reasons why this is a lack of LGBTQ plus welcoming organizations. So folks just are afraid to go to seek care from a medical professional, maybe because of an experience that they've had or because of an experience that one of their peers has had. Many of them may be under or uninsured, especially our trans and gender nonconforming youth. They find it particularly challenging to find employment, even in states where they have non-discrimination policies. It still happens where trans and gender nonconforming people are not hired, or they might be fired from their jobs, and it's just said that it's for other reasons. And there are a number of states, I believe right now it's still something like 23 states where you can legally fire someone for being transgender or based on their gender identity. Many LGBTQ youth have unstable housing or familial support. When they've done population samples of homeless youth, it is quite disproportionate. So, we usually sort of throw out a number like 5% of the population identifies as LGBT, and yet when you look at homeless youth, it's up to 40% of them that identify as LGBT. And many of this is from rejection from their family and that they've left. They also may have unstable transportation, which just makes it all that much more challenging to get to a healthcare provider. This is some very interesting data on teen pregnancy. And specifically, I think that some of this goes back to what I was saying about the bi invisibility and some of the disproportionate outcomes that we see with bisexual people in general. So teen pregnancy actually affects female, lesbian, or bisexual youth more than it does their heterosexual counterparts. It seems that this correlates if they did experience childhood maltreatment and bullying. And this was a very interesting study that actually looked at male, gay, or bisexual youth and how many times that they had impregnated a female partner, and it resulted in an unintended pregnancy. And if these boys identified as gay or bisexual, then it was 2 times more likely than those boys who identified as straight. That these LGBTQ youth have earlier sexual experiences, increased number of sexual partners, and increased times where they had a forced sexual intercourse encounter. Just some statistics on school-based violence. So LGBTQ youth kind of as a whole, 85% of them experienced verbal harassment in school. 58% felt unsafe due to sexual orientation. So again, kind of our LGB students, 27% of those have been physically harassed. 43% felt unsafe because of their gender identity, and 13% had been physically harassed, and 28% had experienced electronic or cyber bullying. So rather pervasive. I think it's one of the most important things that I talk to really all of my adolescents about, regardless of how they identify with their sexuality or their gender identity. For many of these things, it's not how the child identifies, it's just how their peers perceive them. But I do think that if you have a child who has been bullied, that the next logical step is to really delve into their gender and their sexuality, because they are much more likely to identify as LGBTQ if they're the victim of such. So suicide risk, and these are again some sobering statistics. So LGB youth are 5 times as likely to attempt suicide compared to straight peers. One very well reference study says that 40% of trans adults have attempted suicide. I don't believe that we have any real data on trans youth, but just the fact that it's 40% of adults, I think that it probably means that many of them might have done this when they fell into the youth category. And what we do know is that if there is a youth from a highly rejecting family, that they are 8.4 times more likely to attempt suicide than if they come from an approving family or an accepting family. And each episode of LGBTQ physical or verbal harassment increases their likelihood of self-harming behaviors by 2.5 times. So now we're going to sort of switch this to more of a health promotion and really building resilience. So what can we do to create an affirming space? And of course, my background is in talking about sort of how do we create affirming clinics and welcoming environments in healthcare settings. But this sort of stuff here that's on this slide, this translates to everything. This translates to your workplace. This translates to the grocery store, to your church, whatever that it might be. So LGBTQ plus inclusive stickers or pictures or magazines or artwork. So as a gay person, I can speak to just how the subtlest of sign that I would look for and search for in any kind of setting, whether it's at the dentist or the doctor's office or whatever that might be, that I'm kind of just really searching for that little rainbow to reassure me that this might be an okay experience for me. And I think that for those of us who have intake forms, asking those questions, so-called SOGI or sexual orientation and gender identity questions, that is another really, really subtle way. If I get a form and they're actually asking what someone's assigned sex at birth is, or they're asking sort of those sexual identity questions in an inclusive way, then I'm going to take that to mean they're at least welcoming and affirming and knowledgeable enough to ask the question, and that's a good sign. Training staff at the University of Iowa, we have a Safe Zone project, which is a wonderful program. It's 2 hours and there's 3 phases, Safe Zone 1 and 2, and then a trans-specific phase, which includes a lot of self-reflection and group discussion. And at the end of it, you kind of get your official ally placard. And I would assume that many of your institutions have similar, where you can send your staff that interacts with students to a session or a program where they really can leave there feeling empowered to be able to create that space that you want to make sure that all of your students feel welcomed. Gender neutral restrooms. This is probably my favorite placard and sign. I'm super proud that at the University of Iowa, on our whole campus, so both on our undergrad and our graduate and throughout our health system, that we have replaced every single gender restroom sign with this sign here. So no more men's or women's single stalled restrooms. They've all been replaced with all gender restroom for those single stalls. And then non-discrimination policies. So actually having those policies and then posting them in a place that folks can see.
Katie, we have a question here, and that is, will cultural and community stigma through the Library for Youth also be addressed? And this is in response to in hopes of preventing the growth of risk factors in LGBTQ plus youth.
So is the question specific about like libraries? Sorry, can you repeat it for me?
Sure, I'll read it directly from the screen. Will cultural and community stigma through the Library for Youth also be addressed in hopes of preventing the growth of risk behaviors in LGBTQ plus youth? I think you already talked about this in some way of creating an affirming space about the positivity of that, but specifically this was directed to the growth of risk behaviors.
Yeah, so sort of specifically talking, so I don't have anything specifically talking about in library type spaces, and in terms of sort of the stigma that's placed on LGBTQ youth by society, that yes, that these are definitely the things that we think kind of lead to that minority stress, which will increase risk behaviors and negative health outcomes. So by sort of looking at that in an opposite way, and from sort of flipping that lens and saying, well, how can we do this better and create spaces that are welcoming and affirming throughout our communities? And we'll sort of get into some of that too, that the evidence is starting to show that we do see improved health outcomes and decreased risk factors with LGBTQ youth and people in general, not just youth. So confidentiality, and I know that many of you are not healthcare providers, so I'm not going to spend a lot of time on this, but I think that it's pretty important when we do talk about youth to talk about confidentiality. So specifically when they're in a clinical environment, it is I think my #1 job to ensure or to assure that youth that everything that we talk about is confidential. The only reason that I would have to go to one of their guardians is if I was afraid for their safety or the safety of others, and that whatever they tell me about their sexuality or their sexual practices or their gender just stays between us. HIV and STI services do not need parental consent. There may be age limitations depending on states. There's also some interesting things that some states allow if it's in the best interest of the child to communicate with their parents, but they don't require, which still seems a little bit scary to me as a provider. And that laws vary state to state regarding parental notification for other services. And there's a link if you'd like to sort of look how your state takes a stance with that. And across the board consent is needed for transgender care. So I have a really biased sample of transgender youth because their parents are supportive enough to bring them. So I can tell you a million amazing, heartwarming, tear-jerking stories that help me get through a day of otherwise seemingly bad news when I turn on CNN, because I feel like the world is still a pretty amazing place because I have seen wonderful, wonderful interactions of parents who don't understand necessarily, and they are grieving the loss of what they thought their child was going to be. And yet they say at the end of the day, they want their child to be authentic and happy, and they love them no matter what, unconditionally. And it's pretty amazing. And for every one of those kids, I'm sure that there's 8 of them out there that don't come to see me because their parents don't bring them. All right, so family acceptance. So this is one of the ways to improve resilience, and there's many ways to sort of think about that, like in terms of family therapy or providing family with information and education, and all of that sort of thing. This could be a topic all of itself. But we know that when paired with social transitioning for transgender youth, that it protects against depressive symptoms. That when you have family acceptance, that LGBT adolescents have increased self-esteem, perceptions of social support, general health. And with family acceptance, there's up to 50% decrease in suicidal thoughts and attempts for LGBTQ youth. Other protective factors are things like just having role models, whether that is in real life, whether that is in the media, whether that is an actor or an actress or a singer. It's actually having the hope and imagination that their life could be X, Y, or Z, that it could include a loving partner and family and potentially children and a successful job. It's letting them see themselves in someone else. Some of those may be social networks. It seems that LGBTQ youth actually have more online friends and acceptance than their straight and cisgender counterparts. They also do experience more online bullying, but yet they are more likely to potentially find that network online. And sometimes for many of those kids, that might be the safest place that they've found to actually come out and share their stories. Gay-straight alliances at high schools or within university systems, those are another really great way to sort of build up that community support. And then just having school policies, there's been some amazing research that has been done around this sort of policy issue, around things like what happened to the mental health of LGBT people when there was discussion, let's say back in the election of 2004, where there were so many ballots against gay marriage. And we actually saw that there was a correlation with mental health and some of these federal policies. So just having those policies can actually sort of sway which way that we can see people's mental health being. And clearly having school policies, just in terms of being able to use the bathroom that aligns with your gender, requiring that folks use a preferred name, anti-bullying, that sort of stuff, those things really do make a difference and help build resilience and promote health in this population. This is my last slide, just some take-home points. We defined LGBTQ. Sexual orientation, again, remember it's referenced from, though it's very separate to one's gender identity. LGBTQ youth have a number of health disparities, but if we focus on health promotion in this population, we know that we can improve health outcomes. And with that, I'm happy to open it up to questions. I believe we have about 10 or 11 minutes left, Jacqueline, so let me know what we got.
Okay, very good, Katie. Thank you so much. There's been a lot of discussion in the chat. Some of the questions here were we had a question specifically if people have found a digital version of the rainbow safe space logos to be used online.
Yeah, so many of those tend to be copyrighted. So I would sort of look and see, and the only thing that I would sort of caution is that as much as I do think that having kind of those visual representations of safety is that if you have a space that is truly not safe, and yet you put up some sort of a sticker saying that it is, that can almost be more harmful. So I think that having those kind of things are awesome and really great. And I think that the natural thing to go along with it is saying, hey, we're going to do this program, and at the end of this program, we're going to give you this visual representation for you to stick in your office window or whatever that might be. And then you can kind of, ensure that person truly is a safe space. And so if that's the case, if you're making it your own, then I think you can do whatever that you want with it. But that would kind of be a little bit about my recommendation there.
We also had a comment. One of our participants works in West Chicago with mostly Black communities, and says that there is a high stigma against the LGBT community.
Definitely. That is for sure true. And there's been a ton of research on this around all sorts of things, but the one that really comes to my mind right off the bat is HIV risk. And so I know that I touched upon kind of the disproportionate rates of HIV diagnoses among men of color. And many people hypothesize that some of that is because of the stigma that exists in that community. And many of these Black men who are having sex with other men, that they may not be out. So they are more likely to have unsafe sex because they are not necessarily out in an environment that's supportive. So yes, there definitely is, in their specific campaigns, really trying to target that group. How do you get them in and get them tested for HIV? How do you access them to provide them information regarding safer sex and all sorts of things? Similarly, when you look at women, the most common way that that women get infected with HIV in this country is from heterosexual contact. And the population of women that's most likely to, or that is similarly disproportionately affected, would be women of color, so Black women. And so it's thought that many of those Black women are getting HIV from their male partners who are having sex with men. And again, that goes back to the very same thing, just that there is this culture where it's highly stigmatized, and when people aren't out and you have to do things closeted, that it often just does not lead to really safer sex behaviors.
Early on, we had a comment that trans asterisk is not in common usage anymore. They say trans is already used as an umbrella term in many communities. Yeah,
and so I would say that I see them both used still. So trans asterisk or trans. I think that there's probably some regional variation with this. So I think either one of them is probably correct. So trans asterisk written or trans when you're written or speaking.
We also had a rather active discussion about how to answer the phone if a name is not provided.
And so you're saying that you answer the phone and say hello, and the other person says, like, just give me a little bit more here. Like,
yeah. So I
just ask, what's your name? Or hi, who is this?
And the other question was, typically a polite response would be yes, sir, no, sir, or yes, ma'am.
Oh, got it. So trying to avoid sir and ma'am. Yeah, I think that, yes, so in the medical profession, I mean, I feel like when I was training, I had some physicians who very much told me, like, you need to go into every room and say Mr. Smith or Mrs. Jones. And then I had some who would say, you need to say sir and ma'am. And that is quite binary. And so I feel like it's pretty important that we just say, hi, my name's Katie. What can I call you? And so sometimes my little old ladies might say, you can call me Mrs. Smith. And I'll say, great. And sometimes they'll say, why don't you call me Charlotte? And I'd say, great. And sometimes their first name is Charlotte, but their middle name is Grace. And they say, call me Grace. And I'm so glad I asked, because I didn't even know that, because her middle name doesn't even show up on her record. So this isn't something I think for kind of all trans people. I think that this is something that we can incorporate into how we talk to people in general, is asking how they would like to be called, and then using that. So that would sort of be my suggestion, is just straight out asking, introducing yourself. Hi, my name's Katie. What can I call you? What do you like to be called?
We also had a question here. Are there any medical journals you would recommend that consistently publish reliable research about trans health issues?
Yeah, so one of my favorite journals is LGBT Health. They have been around probably like 5 or 6 years, and I think that it's probably amongst the LGBTQ providing health professionals that it's probably one of our favorite that we go to. And so they publish on all things, but trans stuff is included in there.
I have a question regarding PrEP, regarding HIV rates. Have you seen an increase in demand or awareness of PrEP among your teenage clients?
Yeah, so PrEP is, for those of you who don't know, it stands for, excuse me, pre-exposure prophylaxis. And it is taking an HIV medicine, trade name Truvada. So it's taking that medicine every day when you are HIV negative to prevent HIV. It has really good success rates, and just recently, within the last year, the FDA has expanded the indication for it to include adolescents. And so I would say that the uptake for that, or the uptake, is still pretty low. We have a pretty good PrEP program in Iowa. We also don't have a lot of HIV in Iowa. So, my experience here is definitely going to be vastly different than that of someone in a more urban environment. But I do know that across the board, awareness of PrEP, both from patients and prescribers, is still quite low. So we have a lot of work to be done in that field, even amongst adults. And I would assume, though I haven't seen recent data specifically kind of on providers that are comfortable offering it to youth, is probably even less.
Yeah, we got a thank you already. And the question here was, what resources are good for statistics, since governmental surveys aren't very inclusive? I'm going to jump in here and say that I have some resources annotated on the class LGBT, improving the health and wellness of the LGBT populations, on the NNLM training page. And you can feel free to take a look at those resources. And Katie, do you have anything else to offer?
I don't think so. Thank you very much for inviting me. I'm super excited to talk about this topic, especially in this Pride Month. So I really wish everyone a happy Pride. And if any of your local communities are having a Pride celebration, I encourage you all to go. We didn't talk about allyship today, but that is one of the best ways to show your support and your allyship, is to attend and support events like that.
Well, one more comment here about pronouns being not preferred but actual. So
yep.
You comment about that?
Yeah. There are, yes. So preferred gender pronouns is how you often see it referenced in research or PGPs, but yes, they're not preferred. They are just what someone's pronouns are. So often I will just ask somebody, when I'm introducing myself, my name's Katie, my pronouns are she, her, hers. What's your name? What pronouns do you use? I don't often say, what are your preferred pronouns?
Thank you. I just want to say that I put in the link for, and I'm going to add it again, for the MLA evaluation and survey. This is where our participants will be able to claim their continuing education credit. And even if you're not interested in getting MLACE, please do go ahead and do the evaluation. It's in the chat box. It's nnlm.gov. You can see that right above in the chat box there. If any of you have any other questions about resources, feel free to reach out to me directly, and I can help set you up with that. And with that, I want to thank Dr. Katie for joining us today. She's given a really wonderful perspective of what it is like to be a physician who cares for LGBT people, and particularly with youth. So with that, it's 2 o'clock, and thank you very much.
Thanks for watching. This video was produced by the National Network of Libraries of Medicine. Select the circular channel icon to subscribe to our channel. Select a video thumbnail to watch another video from the channel.